Dr. Pei Xiaoqing is a MD and chief physician, PhD supervisor at Sun Yat-sen University's Cancer Center, and he has been specialized in ultra diagnosis and interventional therapy for breast, thyroid, abdomen, and a lot of other conditions. And we would like to welcome her for our opening address for this meeting. 好，您可以开始。
Yeah, and hello, good morning, and dear experts and colleagues, thank you for attending this academic symposium on thyroid microwave ablation. I am Dr. Xiaoqing Pei from the Department of Ultrasound, Sun Yat-sen University Cancer Center. In recent years, with the continuous improvement of health awareness and the country's increasing attention to the development of health undertaking, new technological advancement have provided many favorable factors for the development of thyroid microwave ablation of the treatment technique. Microwave ablation is a novel surgical treatment method that utilizes image guidance to transform traditional invasive surgery into minimally invasive surgery, achieving significant progress in both patient care and medical industrial diagnosis and treatment. We believe that soon microwave ablation will play an increasing critical role in the treatment of tumors. We hope that all the experts present will take part in discussions and share their insights, give valuable opinions and suggestions for the development of thyroid microwave ablation. Thank you all.
Okay, thank you.
Yeah, right.
So next we'll have Dr. Zhu Chengfang. She's the doctor at the Nice-Picos Hospital affiliated to Shanghai Jiao Tong University School of Medicine. We'd like to welcome her to present our first lecture on the management and of complications in thyroid thermal ablation.
Thank you for the invitation. I'm the Dr. Zhu from Shanghai Nice-Picos Hospital, and I'm very happy to give the lecture here today. My topic is the management of complications in thyroid thermal ablation. In my hospital and my department, we have different surgical models for benign and malignant thyroid nodules. But to be a surgeon, I'm still interested about the microwave ablation recently because compared to the normal thyroidectomy, endoscopy, even the endoscopy thyroidectomy, we being a surgeon, we try to from the chest breast or from the oral and the vestibular or from the oral and the submental, even from the x-ray, we try to make the no scar in the neck. But actually, this kind of operation need separate more tissues and need to have the long distance. So actually, this is not very much the minimal invasive treatment. Recently, I think the patients and the doctors, we are really focused on the thyroid function preservation, no scars in the neck, and no hypoparathyroidism, and really ERAS. According to the distance and the recover time, I think this skill is maybe a good choice. This picture, I want to show you the compositions of the thyroid nodules. And from the solid parts, I think from the 0 to 100%. Actually, why I show the picture, because different solid parts, we need to deal with it in different skills, but we don't talk about that today. And also I show the different color, different liquid in the thyroid cyst, from the light yellow to the dark, even the fresh blood inside. And also this one, we can see this nodule, we do the thyroidectomy. When we cut it and open this thyroid nodule, I find the compositions inside just like a mud or the shit. I think if I do the thyroid ablation, they will have the, the completion of that. And also this one, we have the strange inside is just like a gel. This kind of the thyroid nodule looks like a cyst, but actually the materials inside, we cannot easy to take it out. We cannot suck it. Even we put water inside, it's difficult to take it out. So also difficult. And this is like a sesame sauce inside. Different things inside and will make different results. And I think this is important to show you the things inside. And which thyroid nodules are not suitable for microwave ablation. Before, I think some situations not good for the microwave ablation, but now these days I changed my mind. Not recommended before, but now I think just like a small low risk PTC, and for in my department, if it's smaller than 5 millimeter, I think it's better choice. And the multiple thyroid nodules, we describe it as a grape, and with a bunch of grape, we can think it's a whole one and ablate it together. And also the thyroid nodule in the posterior capsule, and if the patients have the important organs dysfunction. But now these days, I think just patient can lie down, we can do it. And but still have some nodules, I don't just suggested it. The first one is a retrostemmal thyroid nodule. I describe it just like an iceberg. I put the picture on the right side because the up part, just the lower part is very big under the clavicle. And actually the ultrasound is difficult to get the good signal and show the good imager. And even we can see it. And actually the if the thyroid nodule regrew again, and it will have the heavy adhesive, and it is difficult to do the second part surgery. So I don't suggest it. And also the large thyroid carcinoma, even the PTC, MTC, and ATC are also not suggest that. Only the small low risk PTC, I think it's good choice. The third one is important structure cannot be fluid isolated successfully. The fourth is severe clotting function disorder, and even some patients they eat the drugs to defense or treat their cardiovascular disease. And so this kind of the cases, I don't think it's good for the microwave ablation. So what's your which side is better, and what's your pathway of microwave ablation needle insertion? Normally, before I try to use the side part, because I think the side part is easy to separate the artery and the thyroid nodule. But this day I changed my mind, because for the angle, the needle part, the top of the needle is easy to touch the nerve, and more patient will have just like a voice change of that. So these days I changed to from the middle part. Even the middle part, we have the just like a space limited tissue for the chin and the chest. But for the good angle, the complications will less. This nerve is also very important. We know it. This is a recurrent laryngeal nerve. Actually, this one is from the vagus nerve, and from far distance to go back, and between the trachea and the esophagus, and go inside the larynx. And for this nerve, the patient will easy to have just like voice change if we get hurt it. And sometimes we can see actually even the PTC, the thyroid cancer is very small, but unfortunately unfortunately, the situation is not good. It's in the entrance of the nerve to the larynge. Sometimes the recurrent larynge nerve is not just a single one. Sometimes it will separate to different branches. And also the PTC thyroid nodules easy to invade the nerve. That's why sometimes this one too close to the nerve is difficult to separate them. And also we have the anatomic variation, just like a no recurrence larynge nerve. So for this kind of the cases, patients easy to get hurt. Actually, we cannot judge it before the operation. Sometimes the patient will get hurt. Even the patient will have the voice come back. The voice will come back maybe after several months. But actually, when we check it, still have the voice called paralysis. How to protect it? Before I talk that, I want to show you the picture. I'll show you the video. For this kind, this patient actually have the parathyroidism. When a hyperparathyroidism, when the nodules is in here, too close to the nerve, I use the liquid to separate them, just like a liquid isolation. So we need to care about the location of the thyroid nodule before the microwave ablation. This here have the triangle area. The triangle area, if the thyroid nodule, if the malignant one is too close to there, it's difficult to separate it, and sometimes we'll have the problem. Also, the liquid solution was used to separate the thyroid nodule from the nerve. If the liquid solution fails, abandon it, no hesitate, I think. When we close to the nodule, we need to move fast and get light energy and short the time. Also, we can use liver technology to make the nodule far away from the recurrent larynge nerve, just like this. We lift it, and to separate them. Okay. This one is a 29 years old female patient, was diagnosed as PTC with BRAF gene mutation, but she refused to get the surgery and request a microwave ablation. We detected PCT too close to the tracheal and cannot be separated by the liquid solution, so we stopped it. Let me show you the picture video. This we do the contrast enhanced ultrasound check, and we try to separate. But unfortunately, the PTC is too close to the just invade the tracheal, cannot separate it. Even we put a lot of the liquid there, so it's not safe, and so we just stop it. This patient is 44 years old female patient, was diagnosed as right side benign thyroid nodule with ultrasound and a fine needle aspiration. So nodule was a 5 diameter, centimeter diameter. She accepted microwave ablation. 1 week later after it, she felt the neck skin red, edema, and painful. The temperature of the location scale was higher, and the low fever also with more cough and more figures. After that, we get a CT scan for this patient. I find that she get infection in the thyroid, and also we can see the little bubble beside the tracheal. The tracheal, we diagnose her as tracheal fistula. That's why she cough a lot and have the fever also. We try to use the endoscopy to check the tracheal, but actually we did not find the the hole, and we give her some antibiotic drugs for 1 week. After that, his syndrome become better. So this kind of things, just like a tracheal injury, we needed to care about that. This patient have the tracheal diverticulum. We detect her before the operation. She have the PTC and want to get a microwave ablation, but before that we check the CT scan and find this one. So we stop it. We think it's easy to get hurt. So it's very important to, before the operation, we need to check the patient carefully. This patient was a 63 years old female and has bilateral PTC, which was confirmed by the fine needle aspiration and the BRAF mutation. She has accepted microwave ablation in another hospital half years ago. She came to my clinic because for the suspected lymph node metastasis. This case is quite early time, so our radiologists don't recognize it. They think the thyroid nodules is 4C. And the patient actually is nervous about that. So I did the fine needle aspiration for the both thyroid nodule and the suspected lymph nodes. But the result is negative. Only the lymph nodes is suspected metastasis. So we talk about with the patient, and patient still want to get the thyroidectomy. We did it during the operation. Actually, for the frozen pathology check, it's negative. Only the lymph nodes metastasis is positive. At that time, I think why I needed to do the totally thyroidectomy, maybe keep the thyroid is better because the ablation is good choice, right? But 1 week later, we get the paraffin section pathology. They said they still have the tumor residue there. We can see the picture. I found the slides for everyone. The middle part is right and no tumor cells, but around it, we check it, we still can find the residue PTC, and this is immunohistochemistry show the residual tumor, and this is lymph nodes metastasis. For this one, I check the PubMed. I find that one articles were published by the Fudan Cancer Center. They said they have the report 12 patients. These patients have the ablation, thyroid ablation before. They get the operation again. These 12 patients, all of them have the PTC residue. But actually, we needed to think about that. This technology was used to the PTC is safe or not. I checked the patients, all the patients, and I find they have the common characteristic, just like both all of them, their thyroid nodules is over than 1 centimeter. I think this is a big problem for the too big for the microwave ablation. This one is a 26 years old female and had the right side nodule 4C, which was 1.2 centimeter. Fine needle aspiration showed a PTC with BRAF gene mutation. Left side nodule is 4A and was 5 millimeter. Fine needle aspiration is suspected cancer. BRAF is benign. And this patient want to keep at most one side. So we did the endoscopy thyroidectomy and for the right side, and the left side, we use the microwave ablation. But during the operation, we said, oh, why not? We after the operation, why not we take off the nodule? We check it. We can find the tumor cells or not. So we did it. We use the microwave ablation to ablate it first and then cut it. We send it to the pathology check and find that there is no suspected tumor cells in there. And so I think, I check it. This is a normal thyroid tissue. This is the tissue change after microwave ablation, and we can see the clear boundary between them. This case is also very interesting. I think this patients, at that time, this is a 54 years old female, was diagnosed as a bilaterally benign thyroid nodule by ultrasound and fine needle aspiration. The nodule was more than 5 centimeters, and she accepted microwave ablation. But during operation, she bleed a lot. She's just like a spray out, just like a fountain. I try to use my finger to press the hole. I try to stop the bleed, but actually she becomes big, hemorrhoma, big hemorrhoma. She cannot breathe well after that. When I lose my finger and just like the blood spray out, I actually at that time I feel scared about it. But I cool down. I try to let the nurse to help me to find where it's bleeding. Okay, this part I use contrast ultrasound to check where it's bleeding. It's bleeding. You can see here. Here, this part is bleeding a lot. So at that time, I put the needle inside and add the energy and stop the bleeding, and the patient be fine after that. I'm very happy because I think this skill is very important. If you know this skill, maybe the patient need to go to the operating room. So now these days, if the needle hole bleeding a lot, I will use this way to stop bleeding. How to prevent and management of bleeding? The first, I think, avoid the visible blood vessel, or if our needle have to pass it, I prefer to ablate it first. The second one, that when we insert the needle, we don't take it out. We just move it inside the capsule. Is more safe. And maybe sometimes we will apply some hemostatic drugs and some epinephrine free into isolation fluid, or post-operation, I will use some drugs for that. And I will have the fellow to help me to press the ablation site for over 20 minutes after the microwave ablation. And also we will use contrast enhanced ultrasound to show the bleeding location, and use the needles to stop the bleeding by higher power. Also, we will transfer if these things didn't work, but actually I never met these things before. Transfer the patient to the operating room, and maybe just do the open operation. And after that, we need to observe the symptoms such as the neck edema and dyspnea after the microwave ablation. The location of the thyroid nodule related the complications. Sometimes too close to the artery, too close to the tracheal, and beside it. This one is too close to the artery. We also use the liquid solution to separate them. The second one is a young guy. He get the total thyroidectomy and even the lymph nodes resection. But unfortunately, after maybe 2 years later, she detected one very small, just like a 2 millimeter lymph nodes metastasis. Actually, for this kind of small lymph nodes, normally for the surgeon, even we do the operation for him, we cannot find it. But for this skill, we are either, if we can separate it with the important structure, we can do the ablation very easy and also very good choice for the patient. This one is too close to the internal jugular vein. We also use the liquid to separate them. This patient also get the operation before. Only one lymph node metastasis on the lateral side. So when we separated it, then we ablate it. This case, actually for the lady, we cannot figure out what's the difference between her two eyes. She come to my clinic, she complained about her right side eyelid cannot open well. Actually, at that time, I find that yes, she had a Horner syndrome, and she also complained about she drink water with coughing. I think maybe the superior large nerve paralysis. I check her where the nodule, thyroid nodule. I find the microwave for the nodule in the upper poly of the thyroid gland. I talk about other doctors and discuss this case. We find maybe because the nodule is too close to the superior part, so the lady get the cervical sympathetic nerve paralysis and superior larynx nerve paralysis. So the nodule in the upper part, we need to care about this kind of syndrome. This is a 30 years old female and 6 cm right side thyroid nodule. 5 needle aspiration showed benign. BRAF negative, she accepted the microwave for the 6 cm large benign thyroid nodule. But 1 week later, this one is bigger and the skin become red and have some tissues. Actually, we pressure it. They have some tissues come out. Normally, for these cases, we need to open this one, but because we just open the needle hole and make the tissue, the things come out, we check it, find that this acts like thyroid tissue, not a necrosis tissue and pus. So I not just totally open it, but I give her some antibiotic for a few days, maybe 10 days. After that, she get a recover, and also the big thyroid nodule decrease the size. These patients also come to my hospital because they accept microwave ablation in other hospitals, and this guy also have the infection, and the doctor in local hospital, they open it, make a big scar here. Also this one, they not happen just like her. They are not happen just 1 day, 1 week. They had these things. They happened almost over 2 weeks, and so after that, they have the infection and the illness formation after the microwave ablation. And for this guy, he have the long time needed to recover. This is a very I think it's a very bad things for the patient because the needle broken in the microwave ablation. So actually we need to choose a high quality microwave needle. For this one, because we know on the top they have the almost 2 or 3 millimeter. This is a microwave come out. Sometimes the needle are not too smooth. So the tissue will around it and around it and cover the microwave part, and the local temperature will become higher and will make this one broken. So actually the top part is still inside the patient. We cannot, we have no way to find it, to take it out. This one also we need to talk about is skin burn. For the microwave ablation, we have the water cooling cycle. But actually, if it doesn't work, the needle temperature will become higher. Actually, the doctor, they hold the needle, they will feel the temperature come out. At that time, actually, we need to change the needle. If we don't change the needle, longer time, the patient's skin will get hurt. And sometimes this kind of patient, they have the nodule is too close to the skin. And if the energy is too high, the skin also need easy to get burned. Other tips, I think we need to care about, check the number and the location of the tumor and figure out the relationship between the tracheal and the esophagus. And we need to find some vascular variation and just like a tracheal and the esophagus, the verticulum. Also, a patient need the ice to cool down the local temperature after the microwave ablation to get less painful and burning feeling. We also need to restrict the condition of the microwave ablation to avoid the infection. The patient needed to be observed for a few hours after it and stop eating and drinking. I think it's more safe for them. For my team, we searched the articles about complications in the PubMed. Actually, we find maybe 355 the articles about thyroid thermal ablation. If the articles talk about the number and the kind of the complications, and it was English, and the full text was available, we use it. And then in the end, we find the 111 articles. We analyze it. We find the complications and the numbers patients we did in these articles. Most articles are from the China, South Korea, Italy, and the American. The number of the different complications in thyroid thermal ablation, not microwave ablation, thyroid thermal ablation is the first one is pain. I think the pain, because the local anesthesia for the skill maybe they are different to different center, and also the voice change, edema, hematoma is on the top 3 or 4, and the tracheal injury and in esophagus injury, this just like a report 1 case. I think is so the incidence of it is not too high. The incidence of complications in different countries. The first one is France. The second one is in New Zealand, Spanish. But I find why the incidence of complications in France is so high, because most of them are pain. I think the pain control is more important. This is a characteristic of complications in each countries. I think for the North Korea, they have the Voice Trench and the pain, also the hematoma. Conclusion, for the time limited, I will make a conclusion. I think the microwave ablation is a safe technology, but we still need to confirm about the burning section at pain, skin scandal and scar, tracheal and esophagus blood vessel injury, needle broken, nodule rupture with or without infection, tracheal fistula, recurrent neurology nerve injury, and superior laryngeal nerve injury, and also the Horner syndrome, dyspnea. The advantage of the microwave ablation, I think, is no scar, just like a local anesthesia can do it. And the time is short. Normally, the patient, they lie down with the local anesthesia just 30 minutes. Over that, the patient cannot handle it, actually, I think. So the microwave ablation is short time. Patient recover very quick. The second day, patient just like nothing happened. And the thyroid function preservation, this is good advantage. And no hypoparathyroidism. If the tumor recurrence is another follow the operation is still fine. The patient with organ dysfunction also can accept the microwave ablation. This advantage is a post-operation tumor cell residue and the recurrence of the benign of the thyroid, recurrence of the benign thyroid nodule, thyroid cancer recurrence and the metastasis. And sometimes it's difficult for the second operation, and the big challenge for the surgeon. This is my lecture. Very happy to have this lecture today. Thank you for the listening.
Thank you. Thank you very much, Dr. Zhu. Yep. So now we will have a brief discussion, and really very appreciated for all the US doctor presented here today. I know it's early Thursday morning for most people. So for Dr. Zhu's lecture, if you have any question, please feel free to mic up and then ask.
And Professor Zhu, I think, how do you select a different power for different nodules? And the solid nodule and mixture nodules, do you use different power for them?
Thank you for the asking. Actually, yes, I use a different power. Sometimes, if the solid part will have the less hemorrhage, I will use 30 watt. If the nodule is easy to hemorrhoma, I will use higher energy, maybe 40. And sometimes, if the nodule with the more just like a liquid inside, the solid part is less than 50%. After the ablation, I will use the enzymal ablation added. Just like a chemistry ablation, added them together to use it. If the thyroid nodule is totally cyst and with liquid inside and almost no solid parts, I will just use enzymal ablation.
Okay. And it seems like Dr. Ko has a question.
Thank you, Dr. Zhu, for your very comprehensive presentation. Just a couple of questions. With regards to the residual PTC, when we traveled, when we had the opportunity to go to China and observe some of your colleagues do these procedures, it seemed like there was a variety of techniques. So for your PTMCs or PTCs, what do you guys aim just for a targeted ablation zone? How much of a safety zone do you overablate? And then were those residual PTCs seen on ultrasound, or were they complete sonographically disappeared nodules that you then saw the residual rim on pathology? So that's one question. And then the second question was with regards to.
Sorry.
Yeah,
Sorry.
do that one first.
So Eric, can you maybe translate it also?
Sorry. Yeah. So basically, I assume Dr. Kuo is asking about the 就是那个
I know.
Yeah, 就是问一下那个 size 是什么样的
啊？
就是 PTMC 就是平时它那个 safety zone 就是比方说最大的这个肿瘤甲状腺肿瘤它的尺寸是什么样的，然后怎么样去对付这些肿瘤。
Sorry
然后
for
会在比方说这个多普勒影像上看到的吗？还是说要通过这个 sonar 啊什么的这些？
Actually, sorry for the listening part. I think for the PTC part in China, normally actually they have the serial for the if the PTC too small, normally we can observe it, don't need to deal with it. But in China, sometimes we think about why we need to waiting for the last time, I mean the metastasis. Sometimes the patient, they think they want to deal with it. And here normally we use ultrasound to check it. And if the suspected thyroid nodule, we have the just like a thyroid classification is 4 or 5. We will do the fine needle aspiration. If the PTC, I think is smaller, 5 millimeter, and I think it's safe to just like do it. We don't use the contrast enhanced ultrasound or use CTC. I don't think it's necessary. Sometimes we just use use fine needle aspiration to check it. But before the microwave ablation, we will use contrast enhanced ultrasound to check the supplement, and also we need check the just like a location of it, and make before and after the microwave ablation, and make sure we totally cover it and no just like a tumor residue. I don't know my answer is touch your question or not.
Yes, it was. It did. Thank you. And then, do you guys routinely do molecular testing on benign FNAs? I saw in one of your cases that the FNA was benign, but it was a larger nodule, and you did a BRAF. You checked for BRAF. So, do you do that routinely?
Yeah. So, yes. Even the nodule looks benign. Actually, we cannot confirm it. Gene mutation, I think, can assist the doctor to judge it better. Normally, actually, we will check more genes such as the RAS, TERT, RAT, and not just BRAF. But for the EDA presentation, I say the BRAF because time limited. I cannot explain too much what the patient get. But normally we will take them to take 8 gene mutation or some just like a gene insert it, right? We have the just like a panel for it.
And if it was a nodule that was smaller.
If the nodule is just like a gene mutation, such as a BRAF with rat, BRAF with turt, we will think of even the results. The pathologist report is benign. We think it's still maybe the malignant. We will stop to do the for the big one. We will not do the microwave ablation.
Okay. If other people have questions.
Thank you.
Yeah, so if I think Dr. Stephanie Lee was asking earlier in the chat, Dr. Lee, if you're here, feel free to mic up to ask your concern.
That was a really wonderful discussion. I don't think that we actually hear enough about the possible complications of these therapies, and I was very appreciative of your honesty in showing us all of these complications. But I have a couple of questions. One is, in practice, how many people are working with you to do these treatments, and how many treatments can you do? Do you do it in just a morning session, or do you do it for an entire day? So how many can you actually accomplish during a reasonable period of time?
How many cases?
Yes.
For this 2 years, we did over 500 cases. But actually, because I'm a surgeon, normally the more steroidectomy just like operation is my main job. My main job, but during it, because I'm interested about the microwave ablation, I think it's good technology, and because I'm really care about the steroid function preservation these days. So I think maybe in the future I will do less steroidectomy, more microwave ablation.
Let me ask the question a different way. How for an average size benign thyroid nodule that's between 2 and 4 centimeters, how long will it take you from start to end to perform this procedure?
If the big, actually for the small PTC, we just take a few minutes, maybe 10 minutes, everything is done. For the bigger one, normally just 30 minutes, 30 to 40 minutes, because the patient cannot lie down longer time. And for the needle, we moving the needle with energy, because we need to the good skill. We can see the top of the needle and to see where is it. It cannot hurt the important structure. If we can do it, and we move our needle inside, outside with energy, so can save the time. So normally the big one for the 3 or 4 centimeter, we just take 30 minutes is fine.
That's amazing. And then what is the largest benign nodule you will do, and will that require more than one session? And the second question was the largest small thyroid cancer that you'll do with this procedure?
Actually, the biggest one is over 10 centimeter. If I have an opportunity, I can show you the picture, because this guy is a 27 years old guy. One side also get the steroidectomy, but this time the right side is over 10 centimeter. But he don't want to take the second operation. They have the scar in here. So the before and after, actually I plan to just like a separate. I ablate it first, let him to waiting for maybe 3 months later. I did it again. I been separated. But this guy, after 3 months, he come back and almost cannot see anything. So he is very happy. He don't want to take any more ablation. He just leave. Now he did not come back. But this is the biggest one, over 10 centimeter. Have the scar to evidence.
And what's the largest cancer you'll do?
Cancer, actually, I compared to the report. And the case I show you, they have the cancer residue and also the surgeon. So I think the 5 millimeter is better. Over it, maybe 6 or 7 is the largest.
Okay.
Oh, after bigger than that, I don't think it's safe.
Okay, excellent. And then one last question. if you have that 10-centimeter nodule and you're trying to ablate the entire volume of that nodule, are you worried about the body's reaction to the necrotic tissue that's left behind? Do you think maybe that is why some of the patients had those skin reactions and fistulas, because there was just this big bag of dead tissue?
Yes, I worried about that, but just try it. Just like a surgeon, sometimes just like they want to try it. We don't know the result. Maybe we talk to the patient and she can accept the result. It's fine.
Thank you very much.
Thank you for asking.
Okay, Dr. Falahati, if you like, feel free to ask your questions regarding safety concerns in the donors of the needle top to Dr. Zhu, if appropriate.
Absolutely. I have a few questions, actually. One is in terms of pre-medication, do you ever treat the patients before starting them, or before treating them with microwave, do you pre-treat them with any steroids to lower their inflammation? If you're thinking it's a large nodule, there will be an inflammatory reaction. Do you put the patients on large dose steroids? We use prednisone in the United States. And I wondered if that is used at all by you. That's one question. And then I would like to talk to you about also the sharpness of the probes or antennas of the microwave device.
Sorry, Eric, I need your help.
So the first question was, Eric, steroid use. Do you use steroids in these patients to keep the inflammation down?
Inflammation 什么叫
就是主要是用的激素，
激素？
用激素啊，对，
steroid,
好像是上对。
No. I did not use it. For the big one, I just give them the general anesthesia. Sometimes for the under the 5 centimeter, I use the local anesthesia. And for the big one, I just give the general anesthesia. After that, I don't use any just steroids. No.
Okay. And then the second issue is, I personally have had problems with the sharpness of the probe, of the microwave probe. When you compare it to, in the US, we use a lot of radio frequency ablation devices, and the probes are pretty sharp. When you use the microwave, and I have worked with different companies, the probe or the antenna is very dull. And even when you cut the skin and then pass the probe through the skin, when it comes to the capsule of the thyroid, you push, and it's kind of hard to get the probe through even the capsule of the thyroid, and you have to really push hard, and it pops and goes eventually inside the thyroid. Why are the probes not sharp enough to just slide it in compared to, let's say, radio frequency ablation devices or probes?
I think I understand it, because I think I needed the company maybe to improve their needle. But for me, I think it's fine. I don't think I need a very sharp one. For me, just like use the needle to open the skin a little bit and put the needle directly. I don't feel any problem to insert it difficult. And actually, the too sharp one, I don't know, because for me, I have the more experience about microwave ablation. For the radio frequency ablation, I don't use it too much. I know it's very sharp, but I don't think this needle is needed too sharp sometimes.
Okay.
Sometimes too sharp, either to get hurt for the artery, for the other parts. For the not too sharp, it's more safe. I feel fine. Okay.
Okay, and then last question. During the procedure, let's say again, I'm talking as someone who uses radio frequency and now on and off also uses microwave. What parameters do you keep and monitor? For example, I noticed with microwave devices, there is no measurement of the impedance. Impedance tells us about the stiffness of the tissue when you apply heat, or the temperature inside the tissue. What do you monitor to avoid charring or burning of the tissue and creating other problems later on?
这是什么？小王？
他就是
您
说
用什么
这个
指标 ？OK，
指标对，
就是你在做的时候怎么监测它里面内部的温度，怎么确保它是熟了还是没熟
？Actually, for some the microwave ablation needle, they have the something to detect the temperature. They actually sometimes the cord is very strong. They can show on the machine. So what's the local temperature there? Sometimes we can see it, and also for the if have the more liquid part, for the more blood inside, I will give the more energy, because not like the radio frequency ablation. Sometimes the liquid inside will low down the energy, right? For the microwave, it's very powerful. So if the more liquid or more bleeding inside, I just use more energy to start to give it. And yeah, and I also from different direction. Maybe sometimes from this one, sometimes I change the ultrasound monitor and from this side to make sure they cross and every part get the well treated.
Okay. All right. Those are my questions. Thank you so much.
Yep. So if we can maybe save some other questions to the next discussion section, but I saw Dr. Bernardo raises your hand. So do you want like to speak up? Do you want to like look up?
Hi, good morning. Thanks for having me. Thank you for your talk. This may not be the right forum for this question, but do you also do radio frequency ablation, or did you in the past? And why do you prefer microwave ablation? Or are there certain nodules you prefer microwave over RFA?
Because for me, I normally we take it to use before I use it the radio frequency ablation, because I feel it's a little bit slow, and for me I like the more efficient, because the patients lie down there, they cannot handle over 30 minutes. For here, normally the patient have the big one. Big one means need more time. So I think microwave they have the more energy, can stop bleeding better, and can shorten the time. So that's why I choose it. And maybe some doctor they have that they are just like a hobby, just like they like with what different kind of things.
Thank you. Are there any nodules? Are there any nodules you would still do RFA for, or you are exclusively doing microwave ablation?
For me, I think microwave ablation is better. Sometimes I saw the doctor they use a laser, but actually I think the point is very small, and even have the higher temperature, but the point is too small that for the big nodules they have the longer time. So I like the microwave.
Thank you. That was all I had.
Dr. Wang Yungjun, she's from the Fudan University Shanghai Cancer Center, and is here today to help us present indication technical essentials of PTC. So we're looking forward to it. I'll give it to you, pass it to you, Dr. Wang.
Okay. Thank you, Eric. Thank you for your introduction. And I will share my slides. Good morning, everyone, and good evening, Dr. Zhu and Dr. Pei. And thank you for inviting me to give a presentation about indications and the treatment techniques of low-risk PTMC thermal ablation. Let me introduce myself. I'm Yinjun Wang, and I work at Department of Head and Neck Surgery in Fudan University Shanghai Cancer Center. And today we will be discussing the current status of low-risk PTMC treatment, an overview of thermal ablation, its indications, and the techniques involved. Most thyroid nodules are benign, and the low-risk PTMC represents a specific subset that we are increasingly focusing on. With the development of ablation techniques, related research has found that ablation can effectively reduce the volume of benign thyroid nodules, relieving patient symptoms such as compression and a cosmetic issue. Therefore, it is gradually becoming a first-line alternative to surgical treatment. However, the efficacy and the safety of ablation in thyroid cancer, especially in low-risk PTMC, remain controversial. When you search online for terms like thyroid cancer and ablation in Google or Baidu, you will be met with various advertisements that use exaggerated language, such as no surgery, no scars, or say goodbye to thyroid nodules in just 10 minutes. These ads are full of seductive promises, and over the past 20 years, there has been a significant increase in the number of studies and patients related to thyroid nodule ablation treatment on PubMed. So let's take a look at whether ablation is truly a sharp sword being unsheathed, or if it's a double-edged sword. First, let us take an overview of the thermal ablation. The basic principle of thermal ablation involves raising the cell temperature to cause tissue coagulative necrosis with irreversible cell death occurring at 50 to 60 centigrade. And the various thermal ablation techniques are differentiated by their method of generating heat. Radio frequency and microwave ablation are most common techniques in treating thyroid nodules. Fixed ablation techniques often seek to maintain temperature around 50 to 60 centigrade for 4 to 6 minutes. And if beyond 60 centigrades, protein denaturation and the cellular membrane disruption result in near immediate tissue necrosis, and will premise for the moving shot technique used in thyroid thermal ablation. This table lists the appropriate ablation techniques that should be chosen based on the composition of different thyroid nodules. For the treatment of PTMC, options such as radiofrequency ablation, microwave ablation, and laser ablation are commonly selected. Then let's discuss how to appropriately select patients with PTC for ablation treatment. Currently, various countries and associations have published numerous expert consensuses and guidelines on the ablation treatment for thyroid nodules. It can be observed that in the early days, the majority of guidelines did not recommend thyroid ablation as a treatment method for primary PTC, or only recommended ablation as palliative treatment for some locally advanced unresectable PTCs. However, since 2021, several international multidisciplinary consensus from organizations such as ETA and ATA have recognized it as an alternative to surgery and active surveillance for low-risk PTMC. It seems that the attitude shifts from strong opposition to becoming more moderate or even gradually accepting. And back to China, since 2015, some associations have published expert consensuses and recommending ablation as an alternative to surgery for the treatment of PTC. However, patients must meet the following criteria simultaneously. First, they have a low-risk PTMC. And second, the nodule is more than 2 millimeters away from the capsule. And thirdly, they have an intolerance to surgery, or they refuse surgery or active surveillance. However, the latest consensus published by the ATA maintains a relatively conservative attitude. The consensus suggests that a cytological indeterminate biopsy results with negative molecular markers and PTMC without high-risk features are relative contraindications for ablation. On the other hand, a cytologically indeterminate biopsy results with positive molecular markers and non-malignancy larger than non-malignancy larger than 1.5 centimeters in size are considered contraindications for ablation. It is evident that the concept of using ablation to treat low-risk PTC is gradually being accepted, but there is still considerable debate. And in this year, a group of Chinese ultrasound interventional and endocrinology experts have published a consensus on the thermal ablation of PTC, which for the first time states it is recommended to use thermal ablation as one of the first-line treatment methods for T1A-N0M0 PTC with strong recommendation and a high quality of evidence. This leads us to ask several questions. Is low-risk PTMC equivalent to T1A-N0M0 PTC, or is it reasonable for ablation to transition from an alternative treatment to a first-line treatment? And even is there sufficient evidence-based medical evidence to support this change? According to the 2022 fifth edition of the WHO classification of thyroid neoplasms, PTMC is no longer considered a special subtype of thyroid carcinoma. And among PTMC cases, 90% exhibit invasive features, including central lymph node metastasis, lateral lymph node metastasis, and extrathyroid extension, lymphovascular invasion, and distant metastasis. And even rare cases can even result in patient death, and the metastatic lymph nodes often signal the progression of malignant tumors. However, and the term PTMC can also lead to misunderstandings between doctors and the patients, preventing an objective assessment of its risks. So how is low-risk PTMC defined currently? According to the literatures, the 2015 ATA guidelines and 2018 Chinese expert consensus, low-risk PTMC must meet the following criteria simultaneously. First, it must have a safe anatomic location. The nodule must be within the gland, not near the trachea and or on the posterior side of the thyroid. And even it should not have any invasive features. There should no clinical lymph node metastasis, extrathyroid extension, or high-risk pathological subtypes. And the size of the nodule should not exceed 5 millimeters. And patient should have no family history of thyroid cancer and no history of neck radiation exposure. And a combined detection of molecular markers such as BRAF, RAS-TERT is required. So the definition of low-risk PTMC encompasses various factors, including anatomic location, the presence of invasive characteristics, very strict size requirements, and high-risk factors and molecular status. It is not as simple as characterizing it solely based on the T1A-N0M0 staging system. Addressing the question of whether ablation can become a first-line therapy, we must then ascertain whether the efficacy of ablation treatment is comparable to that of surgery. Currently, there are different evaluation measures for the ablation treatment for primary PTC, including ultrasound, such as tumor volume reduction rate, complete disappearance, regional lymph node metastasis, and control-enhanced ultrasonography, as well as cytological or histological confirmations. Due to the current lack of consensus of whether a post-ablation biopsy is necessary to confirm therapeutic efficacy, and given that the operation to obtain pathology is even rarer, most assessments are now conducting using ultrasonography. However, this approach may overlook lesions that are not detectable by ultrasound and can be subjected to the subjective experience of the operator, leading to a potential inaccurate evaluation. The left table provides a meta-analysis of the literatures on ablation treatment for PTC or PTMC that has been published on PubMed, with most studies using complete absorption rate as a standard for evaluating efficacy. However, there is a significant variation in the results between different studies, with complete absorption rate ranging from 10% to 100%, and the recurrence rates also vary widely from 0 to 5.6%. Additionally, there are concerns about the small sample sizes or short follow-up periods in these studies. The table on the right compares the 5-year follow-up outcomes of 94 cases of radiofrequency ablation and 80 cases of surgical treatment for low-risk papillary thyroid carcinoma. The results show no statistically significant differences between the two groups in the terms of new lesion recurrence and the lymph node or distant metastasis. Whether this finding is related to the highly selective nature of the enrolled patients remains unclear. And in these studies, which is conducted by a center from Beijing, was published in the European Radiology in 2023. This research analyzed the pathological conditions of 10 PTC patients who underwent ablation treatment and had a subsequent surgery at the center. The interval between ablation and the surgery ranges from 17 to 150 days, with an average of 17 days. And the maximum diameter of the nodule was from 3 to 12 millimeters. The results indicated that there was no tumor residue in the primary site after ablation. While the outcome seems promising, 30% of the patients had lymph node metastasis and occult PTC in their post-operative pathology. Therefore, relying solely on ultrasound for evaluating the efficacy of ablation appears to be insufficient, and the absorption or regression of the primary lesion does not mean a cure for the tumor. Next, we have two studies on patients who underwent surgery following ablation for PTC. The first study reviewed 21 patients who had surgery after ablation. In terms of the tumor size, tumors larger than 1 centimeter showed a trend of reduction after ablation, while tumors that were 1 centimeter or smaller increased in size post-ablation. And this study, conducted at our center, retrospectively analyzed 32 PTC cases from our center and other centers that underwent surgery after ablation. The findings were as follows. PTMC residual was 33.3%. PTC larger than 1 centimeter had a residual rate of 83.3 centimeter, and the lymph node metastasis was 44.4 centimeter. Therefore, based on the gold standard of surgical pathology, the efficacy of ablation is questionable due to its inability to perform lymph node dissection. We will further analyze whether the literature cited in this PTC thermal ablation treatment expert consensus has a high quality of evidence to support the claim that the efficacy of thermal ablation for PTC is not inferior to surgical resection. The first retrospective study conducted a 3-year follow-up on PTC patients with T1N0M0. Although it achieved good follow-up outcomes, the study had the following limitations. For example, no detailed inclusion criteria except for PTC smaller than 1 centimeter, and no concurrent surgical cohort for comparative analysis, and a longer follow-up time such as 10 to 20 years is needed for low-risk PTC. Additionally, there were no reported cases of patients experiencing ablation-related complications. The second study involved a retrospective match of surgery and ablation cases. It reported no lymph node metastasis in 350 T1N0M0 patients, which is quite rare. However, the follow-up period was inadequate, lasting only 25 months. Additionally, some researchers have proposed the probability of active surveillance for low-risk PTC. Among them, the Japanese Dr. Ito, as a representative figure, published a 30-year follow-up result of a large sample, including 3,222 cases in 2023. In his study, tumor enlargement of 3 millimeters or more was observed in 4.7% of the cases at the 10-year follow-up, and 6.6% at the 20-year follow-up. Lymph node metastasis was found in 1% at the 10-year follow-up and 1.6% at the 20-year follow-up. For the management of some low-risk PTMCs, active surveillance can be a viable alternative to thermal ablation as a treatment option. In summary, due to the fact that complete disappearance is not sustained and the disappearance of the tumor on ultrasound images does not equate to the cancer can be cured, the purpose of treatment should focus on preventing disease progression while avoiding surgery, rather than merely eliminating the appearance of the tumor. Based on these considerations, we believe that thermal ablation should not yet be considered as a first-line treatment option for low-risk PTCs. However, for patients with suitable primary PTMC who are unfit for surgery or who decline surgery or active surveillance, ablation may be a viable option to consider. Currently, at our center, we are conducting a study titled "A Study on the Efficacy and the Safety of Controlled Surgery, Active Surveillance, and Thermal Ablation in the Patients with Low-Risk PTMC." Within the framework of such a clinical trial, it allows patients to be fully informed about the treatment options and the expected outcomes for low-risk PTMC, which facilitates the conduct of follow-up work and also serves as a form of protection for both our doctor and the patients. The relevant inclusion criteria have been listed for reference. Now next, let's continue and share some specific optional techniques for ablation treatment. First, for PTC patients who are candidates for ablation treatment, a comprehensive assessment of their overall condition is necessary. This includes evaluating thyroid function and conducting a subjective voice assessment. For those with a history of thyroid surgery or ablation, a laryngoscope should be performed to assess vocal cord mobility. And it is important to note that it is not possible to determine occult laryngeal issues solely based on the voice changes. Therefore, a thorough evaluation that includes radiographic, biochemical, medical, and symptomatic assessment must be completed before ablation. And the emergence of new oral anticoagulants has complicated the peri-procedural management. Generally, antiplatelets like aspirin and clopidogrel are stopped 7 to 10 days before ablation, and the warfarin is paused for 5 days, and the direct oral anticoagulants are held for 24 to 36 hours. All can be safely restarted 24 hours post-procedurally to balance the bleeding risks with thromboembolic prevention. And for patients with significant cardiopulmonary comorbidities, especially presence of a pacemaker, implantable defibrillator, or arrhythmia, physicians should better treat under continuous monitoring. And very important, prior to pursuing ablation, and discussion should be held with the patient regarding expected outcomes and the potential risks. As a fundamental technique in ablation therapy, hydrodissection is a skill that operators must master. Under general anesthesia, normal saline is used as a dissection fluid, and under local anesthesia, a diluted 1% lidocaine solution can be used. A 20 milliliter syringe with a 5 milliliter needle is typically employed, and generally injecting about 10 to 15 milliliter of dissection fluid can create a 1 centimeter isolation zone. As shown in this picture, the dissection can be selectively performed based on the tumor's location. And for PTC, we just said that both radio frequency ablation and the microwave ablation are good choices. And taking the microwave ablation as an example, the active tip of the electrode typically has a front diameter of 3 millimeters. And the ablation area of the electrode is determined by the formula that multiplies the length, the width, and the front diameter. Taking a now in our clinical practice, the output power is typically set between 25 to 35 watts, not exceeding 35 watts. We increase the ablation area by prolonging the ablation time rather than using higher power, which could lead to because the higher power can lead to central carbonization and potentially impair post-operative recovery. And we can take a 30 watts as an example. An ablation time of 10 seconds can achieve a volume of 7.6 multiply 4.4 multiply 0.8 millimeter, while the 15 seconds can extend the reach to 11.1 multiply 5.6 and multiply 0.9 millimeter. Therefore, for PTC lesions smaller than 1 centimeter, an ablation duration of 10 to 15 seconds is sufficient to cover a single plane. And during the ablation, it is recommended to use transisthmus approach to minimize the heat of the in the danger triangle to protect the recurrent laryngeal nerve and the esophagus or the trachea. And even it can minimize the interference from swallowing and speaking, and can provide to make sure the visualization of the entire length of the electrode. And for PTMC lesions smaller than 5 millimeters, fixed ablation is generally used, while for those between 5 to 10 millimeter, a moving ablation technique can be applied. And when finishing ablation and withdrawing the electrode, it should be done with heat to maintain the ablation effect. Contrast-enhanced ultrasound can be employed to immediately observe the ablation zone, allowing for the treatment for any incompleted ablated areas. In the absence of such equipment, the completeness of ablation can be assessed by the observation, blood flow, or by checking for the absence of complete bubble shadow coverage the post-ablation. Generally, post-ablation follow-up with ultrasound should be conducted every 3 to 6 months with contrast-enhanced ultrasound used for assessment when available. The first post-operative follow-up should include a thyroid function test. For benign or large nodules, a cosmetic symptom scores can also be utilized to evaluate the therapeutic outcome. And we really hope the ablation treatment will continue to develop in a standardized and orderly manner. And we can summarize the key points of thermal ablation techniques, including appropriate indications, proper and skilled operative techniques, perioperative observation, and management of complications. And this is all my lecture, and thank you for your attention, and I welcome any questions and open discussion on this important topic. Thank you, Eric.
Thank you, Dr. Wang, for your wonderful presentation on the techniques and indications. So Dr. Stephanie Lee actually had a question for Dr. Pei. So Dr. Lee asked, do you systematic steroids or steroid injection into the nodules after ablation?
No, never. Yeah.
Okay,
yeah. Because
never.
Because the pain and the edema is all controlled, and we will give a patient the iceberg to cool down the foci, and they will feel better when the skin was cooled down.
Okay. Okay, great. Thank you. Okay, so if anyone else will have a question, please. So Dr. Guo, go ahead.
Hi, thank you again for a great presentation. And sorry if I missed it. In your proposed clinical trial for thermal ablation as primary treatment of microcarcinomas, have you considered or do you plan to have an arm for just active surveillance?
Yes.
So you'll compare the two outcomes long term?
Yes. We give in this clinical trial, we give patients three choices, including surgery, ablation, and active surveillance. Yeah.
Okay. And it's just for less than 1 centimeter cancer.
Yes. And even we have a stricter size requirement, even smaller than 5 millimeter.
Okay.
Okay, thank you.
Yep. Anyone else? Dr. Dindra, saw that you have your mic on. If you have any question, please just voice it in. Or anyone else, because I think a lot of us will have shared or common questions about the technique. So.
Hi, this is Stephanie Lee. I don't do any type of ablation, so this is a silly question. So I assume that you're using a linear ultrasound probe, and then what frequency are you using to guide your needle?
You mean the frequency?
Yes.
I don't get your question.
Frequency of the ultrasound, not the power of the microwave.
You mean the ultrasound frequency?
Yes.
Because I'm a surgeon and I'm not so familiar with the ultrasound machine, but we usually use the probe of thyroid to detect the nodule. That's okay.
Okay.
And then no specific requirement for the frequency. Yeah.
So another technical question, are you handling the ultrasound probe and the ablation device yourself, or are you having a technician do the ultrasound?
I always do it by myself. Yeah.
Okay. Thank you.
Thank you.
Okay. We also have another doctor who just joined the meeting. Let's see. Okay, Jennifer.
Sorry, one more question. You presented the table of power and ablation zones that you use. So, is it safe to assume then that you guys use more of a fixed ablation technique where you place the tip of the antenna in the middle of the tumor, blast it with energy, and that's it? Or do you actually then sort of move the tip or use a modified moving shot technique?
Yeah. This is a good question. And I think for PTMC, usually we now conduct the ablation for the PTMC size smaller than 1 centimeter or even smaller than 5 centimeter. We often use the fixed ablation is enough, because if we prolong the ablation time to 10 or 15 seconds, the area of the ablation will is around 1 centimeter to multiply 1.5 centimeter. I think it's enough for the micro papillary thyroid carcinoma. Yeah, and for any larger nodules such as 2 centimeter or even larger, and the moving shot is a good choice. Yeah.
Hi, Dr. Wang. Yeah, I have a question, and I want to the question is, how about the dose? Do you use the Thyroid after the PTMC microwave ablation, and how about the dosage of it?
Yeah, I think it's a quite debatable question, and as to the active surveillance, there is no criteria for whether to give patients urothyroxine to control the TSH. And so in our clinical trial, we also did not make a very strict criteria for patients to control their thyroid function. And but we will let patients to take a thyroid function at the first follow-up around 3 months. And if the thyroid function is over the normal range, then we will give the urothyroxine. And if it is normal, just let it be. Yeah.
Okay. Welcome, Dr. Nwagu, and welcome to the doctor who's just joined. If you have a question, and just a quick heads up of where we're at. So basically, we already had 2 Chinese doctors presenting their discoveries, and now we're in the discussion section. So guys, feel free to ask any questions, and if there's anything come up, we're happy to answer. Yep. Hi, Dr. Nwagu. Nice to meet you. I know it's pretty early for you on the West Coast, and thank you for all the doctors who participated from the West Coast.
Hi, this is Dr. Feng also from West Coast. I have a question. You talk about more about thyroid cancer treatment. Can you talk a little bit more about thyroid nodule, benign thyroid nodule treatment?
What's the question you want to know, or any specific techniques or skills you want to know?
You mentioned nodule size 2.2 to 4 centimeters, is that right? And is that certain you also said a posterior thyroid. So I do not understand exactly what kind of nodule will be the best indication for you to go through the microwave ablation treatment other than surgery.
Oh yeah, and we in our center, if the patient with a large nodule and cause some compression or cosmetics issues, we will recommend surgery as a first-line treatment. And if the patient is very young or not able to accept the surgery, and we will suggest that he or she can take a ablation. And I think the size is not only the only standard criteria for whether to give the ablation. And the main criteria of whether to give the ablation is whether there is any symptoms or whether the nodule is growing gradually. And if the patient worry about the gradually growing nodules, and we take a fine aspiration, and the nodule is benign, then we can also give the ablation for the patient to treat the nodule. Yeah. And I think the size is not only the only criteria.
So usually treatment, you just need a one-time treatment, or you need a repeat treatment?
As to according to our experience, the nodules, it depends. Depends on the composition of the nodules. If the nodule is cystic, it's all wholly cystic, and we may give some ethanol or some chemical ablation at first time. And after 1 or 3 months, the nodules will shrink, and we can give a thermal ablation for the second time. And for the nodules wholly solid or mostly solid, then the size is not too big, for example, smaller than 5 centimeters, and we will give a ablation once. And according to the follow-up data, the nodules smaller than 5 centimeter will shrink, the volume of the nodule will shrink around 60 to 80%. And I think that's good for the patient enough. And it's not very emergent to consider a second ablation.
So if for the nodule gradually increase or TR3 or TR4 or something, you do require a pathology biopsy, or so you have any concern about possible cancer or something, you do a fine needle aspiration or core, biopsy to rule out the cancer first, right?
Yeah. We make every patient to take the biopsy pre the ablation. Yeah.
Thank you so much.
Thank you.
So this is Stephanie Lee. I have a question. So if you do a biopsy and you get an indeterminate cytology and your molecular markers are negative, do you consider that to be a benign nodule and you'll do the ablation?
Yes. It's a very debatable question. And for patients with indeterminate nodules and the molecular status is negative, and if the thyroid, if the ultrasound give us a category also up to 4A, and I will recommend the patient to accept the surgery as a first-line treatment. And if the patient did not decline the surgery, and I say I will give you an ablation for a try. And 2 weeks ago, I just met a patient. The patient is a female, and she accepted the ablation 1 year ago. And at that time, the nodule was 4 centimeters, and the final aspiration is AUS indeterminate, indeterminate, and the molecular status is negative. And I offered the ablation for her. And however, the nodule never shrinks anymore. And after 1 year, she come to my clinical, and I take an ultrasound for her. And there is still many blood flow in the nodules. And I suggested her to take an operation. And the pathology after the pathology after the surgery showed us she has a follicular cancer. And I suppose that there is there is still many efforts to continue to make sure whether the indeterminate nodule should be cut or should be ablated. So it's quite debatable, and I think it should be discussed between doctors and the patients. And the patients, if really realized that the ablation may be fail, and she can accept the probability, and we can give her the ablation. Yeah.
Okay.
Yeah, I mean, you mentioned that your molecular markers, you just do a 6-gene panel, which will actually miss a fair number of cancers in the United States. So Dr. Kuo from Columbia, can I ask whether you, if you use one of the United States products, either Afirma or Thyroid, which has a negative predictive value of, you'll miss it 3% of the time, which is the same as a benign biopsy, would you do an ablation with an indeterminate biopsy and a negative Thyroid or Afirma?
Yes, thanks for the question. We actually do have a clinical trial looking at Bethesda 3. We just expanded to Bethesda 4. Nodules that have been molecularly profiled only with either Afirma or Thyroid. We do not accept Thigenex or Thyromere. Those we test a second biopsy with either Vericide or Thyroid. So as long as they are molecularly profiled benign, we can move forward with ablation. And we're just about to publish our preliminary data, but we do see similar outcomes, volume reduction outcomes with those nodules, similar to our benign cohort. And there have been 2 additional studies that just got published out of Europe and Asia, I believe, respectively, where they've demonstrated similar outcomes, although their Bethesda systems, cytology systems and such are slightly different than, the ones that we use here in the US, but there is some early data now that the outcomes are similar as long as the genetic signature is benign.
So in your study, did you miss any cancers?
We don't know. So that's the thing is, when we don't necessarily take out the nodule at the end of the day, we don't quite know, but their volume reduction is similar to that of benign nodules thus far. Our only miss was a very unusual case of metastatic UCC that happened years after the ablation. So that's going to be an outlier, but I think the majority is in the early phases, it seems to be equivalent to benign disease. Now, I think cancers can be missed even in indeterminate not cytology. There's quite a few large benign nodules where I think that risk actually may be even higher. And that's an area I think that's kind of evolving, and we're trying to figure out that problem.
Yeah, this is Dr. Feng again from the West Coast. So I have a question with those genetic frequency tests. I'm an internist, so I'm not 100% sure about these things. So are those tests only run on those clinical trial, or regular medical center will run those genetic tests? In the United States,
Can I answer that for the United States? So the molecular testing is pretty standard these days in both community and academic centers. You just need to make sure that your pathology department will send them out, and they're generally paid for indeterminate biopsies. That's Bethesda 3 and 4, and they're just starting to try to get them approved for 5 and 6s, which is suspicious and positive. But certainly for indeterminates, there's some caveats. They can't obviously need surgery regardless of the results, but generally all insurance companies will pay for it now.
Okay, thank you.
So not to bring this up again, because I just want to make sure, because this is what you presented with microwave is very different from what I've heard for RFA. So you're telling me that in relatively large nodules, let's say less than 5 centimeters that are benign, that you can ablate it in one session that will take you less than 30 minutes, and you'll expect a 60 to 80% reduction in volume of that nodule. Is that correct?
Honestly, the same as Dr. Zhu. And I think the 30 minutes only means the ablation time. And actually, we need some preparation time. And preparation time may last 10 to 20 minutes. And we need 5 minutes to give the hydro dissection. And when we really give the ablation, I think the time is 30 minutes. 30 minutes is enough. And the longer time the patients, especially for the patients with local anesthesia, they cannot endure.
Okay, so do you, for your schedule in your clinic, do you save out then an hour for each patient from start to end?
You mean 1 hour?
Yeah, so by the time you bring the patient in, you do the hydroprotection, you consent them, you give the anesthesia, you do 20 minutes of pressure after the procedure. Does that equal about an hour, or are we talking about 2 hours?
Around 1 hour. And at the very beginning, I trained my skills, the ablation, and I may take 1 hour, even 2 hours. And after 50 cases, I trained, and I think the time will be could be short. And now, if I conduct an ablation for patients around 4 or 5 centimeter nodule, and I think I take 45 minutes to 1 hour is enough. The total procedure, yeah.
So, and then can you tell me how many of those patients with large benign nodules, again, we'll say 4 to 6 centimeters, do you need to do more than one session? So you have to bring them back 3 or 4 or 6 months later and repeat it?
No, I never repeat ablation until now, yeah.
All right, thank you.
Yeah.
Dr.
Okay,
Wing, do you guys do it in the operating room, or do you guys do it in your office?
In the operating room, yeah. And with the monitoring machine, yeah.
And so your recovery is not in the operating room, your recovery observation of the patient is in a recovery room.
A recovery room is not necessary. Yeah, after ablation, the patient always go back to the ward, and they will lie on the bed for 1 or 2 hours with ice pack to cool down. That's enough. Yeah.
Do you pre-admit your patients?
What do you mean?
Do you pre-admit your patients to the hospital before the procedure?
Yes, we have we create, yes. And the patient always walk to the operation because the patient needs someone to guide them to the operation room. Yeah.
Thank you.
Thank you.
Dr. Wang, I have a question. Ali Falati from Salt Lake City, Utah. I was wondering, how long do you wait if you have to bring a patient back for a second treatment because of the size of the nodule? How long do you wait before you bring the patient back for a second treatment?
Until now, I have never give a patient a second treatment, but I only give a patient I just talk about the case. I give her the surgery. I think 1 year. 1 year is 1 year. The nodule will not absorb over 1 year. 1 year is enough. Yeah.
All right. Thank you so much.
Thank you.
Okay. Yep. Dr. Pei.
Yeah. 我们是不是结束讨论？
Yeah, so if no further questions, then very grateful for everyone's participation today. This is our 3rd meeting of the series, and we're definitely going to have more in the future. So right now, I would like to let Dr. Pei to make a conclusion for the meeting, and then we'll see you guys next time.
Yeah. Hi. The time goes fast, and so much for everyone. It's a wonderful presentation from Dr. and Dr. Wang. I think from this symposium, we can learn more about management of the complications in thyroid thermal ablation and more knowledge about the thyroid microcarcinoma ablation on PTMC. And this is a spirited discussion. So thanks everyone. I see that's all. And good morning, ma. Good.
Yep. Okay. Yeah, thank you, Dr. Pei, and thank you especially to Dr. Jennifer Kuo, Dr. Stephanie Lee, and Dr. Phil Hality for the active past participation and questions. So I would like to thank everyone again, and we look forward to our next meeting. And in the meantime, if you have any questions, please don't hesitate to reach out to the Barrett team. All right.
Okay, thank you.
Okay.
Thank you.
Thank you, everyone.
Thank you,
Bye.
everyone.
Okay.
Bye.
Bye.
Thank you.
Bye. Goodbye.
Bye.
Thank you.
Thank you.